And we go from, just again, just a wonderfully insightful session about what drives valuations and how they're determined to really another one now with, you have to call him one of the co-founders of the digital health ecosystem, coming, a native San Diegan. You don't see many of those. You don't see many native Californians. and kind of doing the healthcare executive startup thing in San Diego County back in the 90s, exits a company and joins Qualcomm, which is, I don't know, Don, we have to figure out how to quantify this, but one of the corporate folks who've invested probably more money or as much money as anyone else in the digital health ecosystem over the last 30 years. And as a result of that, he runs into someone by the name of Eric Topol, who then writes a book about digital medicine, and that gets turned into digital health. And so Don Jones is here today as one of the folks who was there at the very beginning and helped drive it. And with Ron Dixon, again, who just completed another major raise. And Ron, congratulations on all your success with CareHive. And with that short introduction, I will pass the virtual microphone over to Don and Ron.
Thanks, Dan.
Don, you're on mute.
Sorry about that. Thanks, Dan. Thanks for the opportunity to work and meet the audience today. I'm glad to be here with Ron Dixon, the CEO of CareHive, who I've known for quite some time. And Ron, you and I first met when you were Chief Medical Officer at Onduo.
That's right.
And now you're the CEO of a startup. So maybe just to kind of start things off, maybe talk about what the difference to you meant, switching gears and switching hats from CMO to CEO.
I mean, the difference is significant because the CMO is really focused on evidence generation, clinical validation, making sure that what we're doing has reality in the clinical realm. And now I'm really focused on the people, making sure that I have the best people available for the team that we're building. I focus on the money, so making sure that we have the right financial status to keep our team going, and then the strategy, like what are we actually going to do, and what do we do, 1, 3, 5 years from now.
So when I met you at Onduo was in the virtual first diabetes care space, and you ended up leaving Onduo and were recruited to a company called Remedy. What was Remedy doing when you first landed? And,
Yep.
And what are they doing now? And then we'll get into a little bit about why a pivot occurred.
So I think there's a little backstory, Don, and I'm going to try to tell it really quickly because we have like 7 minutes or something. The backstory is that I started a company in 2009 that was focused on asynchronous engagement of patients with chronic disease. I'm a physician by background, and I really believe that I believe that telehealth had a big future. And I started that work back in 2005. And we did a study of first face-to-face versus virtual visits back in 2006 at MGH. And we didn't really find that there was a lot of time savings in the synchronous video world. And that's what led me towards asynchronous. And I thought that asynchronous really could bring data to the picture because you get quantitative responses to question sets. And we started to use asynchronous engagements of patients with chronic disease like diabetes and depression as a form of follow-up. And the quick story was we scaled it at MGH. We built it like a startup. I got investment from MGH. And at the end of the day, there just wasn't enough value because what you're doing is taking away fee-for-service visits and replacing them with technology that's far more efficient. I ended up leaving MGH to go to Onduo to take on that role. And then some of the investors that looked at 360, the company I founded, they called me in 2020 during the pandemic and said, we ought to take another look. We think you can bring this IP over to this company called Remedy, which was focused on virtual urgent care and had a telehealth approach to virtual urgent care. And they also had a last mile of care service where they would go and complete the needed service, whether it's a lab test or a blood draw, so to prevent you from escalating to a bricks and mortar to more expensive site of service. So I joined that company during the pandemic, July 2020, and the company in the midst of the pandemic chased COVID and COVID testing which resulted in some significant fiscal challenges. And at that point, the investors said to me, well, why don't we pivot it back towards what the original thesis was? And the original thesis was, let's leverage asynchronous communication, leverage asynchronous content, and then leverage data science so that you could be much more predictive about the level of care that's required for a patient in a truly hybrid model. So that if you have a patient with depression that requires follow-up, for example, you might simply need to engage them with sets of questions from a page Q9, for example. And that would allow you to estimate and assess them and then escalate them appropriately. It might just be that they need a care navigator to manage them and say you're doing well. But it might be that they need an escalation to a psychiatrist urgently. And if you then think about expanding that over time, you could expand that over numerous conditions, which we actually built the content at MGH. And then as you do more and more interactions, you get to this idea of learning, of automation and learning, so that you can now say, well, this person needs this and this person needs that. You get to this idea of predictive analytics that's applied to chronic disease management.
So I happen to be a big believer in asynchronous communications. I actually wrote a bunch of patents on that are under a category called asynchronous mediated communications. And so I'm very curious in terms of that origin of your thinking, and now what have you found in your or what's your thesis about how much more efficient an asynchronous based provider can be over traditional synchronous communications and operations in healthcare?
Well, that's one thing that we actually did test. So to the prior speaker around getting evidence, like I'm a big believer in actual generating evidence. And one of the reasons we were able to scale previously at MGH was that we promised to develop some peer-reviewed evidence around the efficiency gains in asynchronous versus synchronous in terms of chronic disease care. And we basically found an 80% savings in terms of time and equivalent quality. And what that allowed was a scale at MGH and this inherent belief that if there was no barriers to the payment system and the way that clinicians are paid and the way that healthcare is typically delivered, if we could get ourselves out of the age of the, I like to say the typewriter, and start thinking about, well, what's the appropriate level of care and engagement that you could leverage to really get a patient to respond with the lightest, we call it the lightest dose of care. So the lightest touch to get the information you need to make the decision about the patient might allow the patient to live their lives. Because when it comes to healthcare expenditures, chronic disease is a big piece of healthcare expenditures in the United States. A lot of us have chronic diseases like mild hypertension, for example. And why not leverage technology and leverage asynchronous to really engage you to get the best care that you need?
Yeah, I mean, it's interesting. Obviously, we all experience asynchronous communications in our lives using text messaging and email, but we don't think of it so much necessarily as a core infrastructure or tool of our businesses necessarily. In other words, part of the business workflow, integral into the workflow platform of how things actually get done. We're starting, obviously, over the last 5 years to see that in software development and technology company development with platforms like Slack. What do you think it's going to take in the I guess the education of physicians and perhaps the deployment of healthcare professionals in hospitals to actually think about how to think about asynchronous first, as opposed to thinking traditional delivery models?
I think that we need to actually decompress providers, especially in the setting of the pandemic. And as somebody who practiced for 18 years, there's just so much that comes across our desks. So I think one way that you could get buy-in is to not make it be reviewed by the provider and have an ancillary workforce that, again, leverages algorithms and data and analytics at first to help with that, what I would like to call triage. Basically, what we're doing is figuring out a way to use different resources to help prioritize patient care. One thing that always frustrated me as a clinician was patients would come into the office and there'd be absolutely no prioritization and stratification in terms of risk. And what data science allows you to do, and asynchronous collection of information allows you to do, is actually be much more strategic about stratification and understanding where, do you need to see that patient, or is there another mechanism that you can engage and get the right data and manage the patient in a way that's better for both you as the provider and the patient. And if you can do that in a more efficient way, then that should create value. And that's why I think you're going to see over time the people that are getting the value, which typically people who are paying, are going to start embracing this, as long as there's evidence to suggest that there's both value created and there's clinical outcomes that are efficient, or that are just as effective or even better.
You're making me imagine in my mind that there's a possible triangle of features that could come together that'd be very valuable. One was asynchronous communications. The other one is obviously evidence and the AI elements that take that build that evidence. And then the third piece is standing orders. Do you see those three things coming together?
Absolutely. Standing orders are a part of how we currently manage some of the workflow in our clinics. And again, we do have a hybrid approach where we will first evaluate the patient, again, using our kind of asynchronous digital front door, and then escalate up the navigation pyramid. And that's where you'll see the standing orders in terms of, having a nurse escalate to the provider for a virtual visit as needed to help manage the patient. And I think you're just going to see that. I think that's a part of our model, but I think you're going to see that as a part of the growing clinical model going forward. Again, I can't say enough about not putting it on the backs of especially primary care doctors. You got to find a way to decompress primary care doctors and allow them to have some room to breathe, especially in the pandemic.
It's interesting. I grew up in emergency medicine and emergency medical services, where I discovered that standing orders are kind of crucial, the absolute cornerstone of how paramedics practice. And then and of course, they deal with some of the sickest, most injured people in the world as a result of 911 related incidents that they respond to. And then I discovered that another place where standing orders are very, very common and prevalent is in the ICU, another place where we have very, very sick people. And then in the middle, we don't use them at all. So is it interesting? Do you attribute that mainly to the way practitioners have gotten paid as a way to not think that through? Or do you have other reasons why that's not the case, why we haven't seen more?
Yeah, I do think that there has, like, if you look in the typical clinical workflow in a busy practice, you'll see some use of standing orders for certain common urgent complaints with nursing. In terms of more generalized use of standing orders, I do believe it's a matter of the way that medicine has been practiced, and we're kind of locked in terms of the time that we have with the patient, and then the time that we have to document, and the time we have to bill. That prevents really thought processes that would enable a lot of innovation and automation to make things better. But I do think that there are some groups that are working on that.
Well, thanks. Maybe with one last sentence, what will CareHive do to drive its model into the traditional healthcare system? What'll be the secret sauce?
I think at the outset, it's all a matter of aligning incentives. So we are working with people who have responsibility for the dollar in healthcare, but we have to incent both patients to work with us and providers to trust us. Healthcare is relationship-based and trust-based. And as we grow, we need to gain trust and provide evidence of what we're doing is both providing better quality care and saving dollars and providing some relief for overburdened providers.
Thanks, Ron. That was great. Stan? We're all
Again, Don and Ron, thank you very much. We're going to have you guys on a regular basis. The Ron and Don show. Really appreciate you both joining us. Wonderful. Again, just a ton of valuable information there. And heard now several times over the last few hours. Again, Ron reiterated the need for evidence and reiterated what Richard Hanbury, again, another startup CEO doing very well in digital health, also said, which is that evidence is not a bar, it's a ladder. And the more evidence and the more data that you can get early on in your startup, the better. With that, we have another environmental biodynamics question for you for winning a signed copy of the book from Professor Ora. And the question this time is, by what percentage did the global digital therapeutics consumer base grow between 2019 and 2021? A, 288, B, 305, or C, 354? Don, what is your answer?
I'm gonna guess it's C.
C, 354. I would go with that. And the answer is A, 288. There we go.
We're all close.
You know, Jerry and Julia, they're always trying to put something up the sleeve there. They led us astray. All right, well, really good question. And again, the chat box went crazy with answers. And we did have a lot of C answers in there. So Don, you can take comfort in that you were not alone. A few A's, but we definitely have a winner there. So congratulations on your your hosted your signed book from Professor Ora on bioinformatics and environmental